السلام عليكم ورحمة الله وبركاته. بسم الله والصلاة والسلام على رسول الله وعلى آله وصحبه أجمعين. I cannot make it more closer unless I swallow it. يعني. Please raise the volume, please. طيب طبعا this is a very hot topic, and I understand why the attendance is so huge, and everybody is concerned because this infection is spreading, and a lot of people, not only public but also healthcare workers, are really extremely worried because of the healthcare workers who have been recently infected with this infection. So this lecture is meant to give you a brief description of this new syndrome and some of the epidemiological features, clinical features, and preventive measures. يقولوا صوت مو واضح. طيب كورونا فيروسز اللي هي الفيروسات التاجية. This is how it looks under electron microscopy. Just before we start with the clinical features, just for our students, to just show them how we classify respiratory infections. We classify them into upper and lower respiratory infections. The upper includes the nasal cavity, infection of which is called rhinitis, manifest usually as rhinorrhea. Pharynx, manifestation of which present with sore throat, difficulty swallowing. And larynx, manifestation of which present with hoarseness of voice, and sometimes even complete absence or aphonia, complete absence of voice, along with cough. The lower respiratory infections include tracheitis, bronchitis, and pneumonia. The upper respiratory infections can get complicated with sinusitis, otitis media, bronchitis, and viral conjunctivitis and diarrhea as part of the upper respiratory symptoms. We have more than 200 different viruses that can cause upper respiratory tract infections, including rhinoviruses, which are the most common ones, coronaviruses, the parainfluenza viruses, adenoviruses, enteroviruses, and respiratory syncytial viruses. Another cause of upper respiratory tract infection is influenza virus, but this one tends to cause systemic disease. Systemic disease, not just rhinorrhea and sore throat, but it tends to cause really severe myalgia, arthralgias, high-grade fever, bone pains, etc. And we also have a bacterial cause of upper respiratory tract, which is the Streptococcus pyogenes, or also known as group A Streptococcus. And up to 15% of patients with sore throat or upper symptoms have this bacteria as a cause in adults. And in children, up to 37% have bacteria as a cause of this upper respiratory tract infection. It is a challenge when you have in the clinic somebody with sore throat. Is it MERS-Corona? Is it bacteria? Is it other viruses? So these are some of the clues that can help you differentiate between bacterial and viral upper respiratory tract infections. This is basic stuff. I'm sorry to say them, but because we have a lot of students, it's good to go over them. If your patient has conjunctivitis, if your patient with fever and upper symptoms have conjunctivitis, or coryza, runny nose, or cough, or the other ones, such as diarrhea, hoarseness of voice, discrete ulcerative stomatitis, red irritated eyes, or exanthema. These features suggest that this patient has a viral illness. It doesn't have to be MERS-Corona, but it could be any of the other viruses. The features that favors bacterial or group-based streptococcal infection include sudden onset. Patients usually with group-based streptococcus pharyngitis have sudden onset of fever, and they are usually sicker than patients with viral infections. They are usually young, between 5 and 15, but can happen also in adults. They often have high-grade fever, headache. They may have nausea and vomiting and abdominal pain. They may have tonsillopharyngeal inflammation and exudation in the tonsils. So you may see pus in patients with bacterial sore throat. They may also have cervical lymphadenitis. And also one important feature, if you see petechiae in the palate, this favors group-based streptococcus over viral infection. This is just an example of how group-based streptococcal pharyngitis looks like. You can see the purulent exudation on the tonsils. This is another one. This is the petechial rash that you may see in patients with group-based streptococcal infection. So if you see these features, then you have to give your patient antibiotics, amoxicillin, if you think that the cause is bacteria. It is better to confirm by doing culture or rapid test for group-based streptococcus. But if you're not sure, if you're in a peripheral hospital, if you're at home and you don't want to go to a doctor, if you have any of these features, then you should take only amoxicillin, not more than amoxicillin. Now, we go on and talk about coronaviruses. This family of viruses infect and cause disease in a wide variety of species, including bats, birds, dogs, cats, pigs, mice, horses, whales, and humans. So not only humans are affected with coronaviruses. And recent studies have suggested that bats are the reservoirs for most of the coronaviruses. And these viruses may cause respiratory, enteric, hepatic, or neurological disease, which may have variable severity. Now, if we go back to the 60s, we had two coronaviruses that caused simple, self-limited upper respiratory tract infection, which is the human coronavirus 229E and human coronavirus OC43. These were the coronaviruses that used to cause simple common cold, which we call cold, اللي هو الزكام. Then a surprise happened in 2003. I'm not sure why this sound is coming. Now? الصوت هذا شوي فين جاي؟ طيب. In 2003, a surprise happened. A disease that killed many patients in China, widely spread all over the world because China government did not announce the presence of that disease until it spread all over the world. And it killed about 800 people, affected about 8,000 people. And this syndrome was called SARS, severe acute respiratory syndrome. And the virus that caused this SARS was a coronavirus, was confirmed to be a coronavirus. And the origin of that SARS virus was found to be cats and other animals that lived in China. They have some habits of eating meats, having very close contact with these cats. Like we deal with chicken in our community, they also deal with cats this way. So they had this SARS originating from China and then spreading all over the world. And it killed so many healthcare workers. And it was first believed to be a droplet infection. Droplet, yani heavy respiratory nuclei that can only infect people when you come very close. They initially thought that SARS is a droplet infection, but actually they found later on that it was airborne. It was airborne. Even though it's a coronavirus, the previous coronaviruses were droplets, but the SARS that was discovered in 2003 was found to be actually an airborne infection. So this new coronavirus may behave like SARS. It is not SARS, but it may behave like it. The SARS epidemic vanished. Within 6 months, it vanished. طبعا, WHO was heavily involved, and they put stringent plans to get rid of the infection. Then, between 2003 and 2005 and 2012, we had 2 more coronaviruses that also caused self-limited simple respiratory tract infection. So before this MERS corona, we had 5 viruses. One of them was very serious, the SARS one, which disappeared, and 4 that was still circulating in the community, causing only simple infection. Until June of 2012, when another surprise happened. This surprise was a patient who was admitted to one of the private hospitals here with severe pneumonia. And the treating physician sent specimens. To try to identify the etiology. Nothing was identified. The virologist in that hospital inoculated the specimens, or the sputum specimens, in virus cells. Okay? And then, to his surprise, he grew a virus that was not identifiable in his lab. He asked for help from another expert in Holland, and that expert did further studies on it, and they found that actually it was a new virus that killed that particular patient. And this was in Jeddah, in a very close hospital. This man was 60-year-old who was previously healthy, and he died 11 days after admission with respiratory failure and renal failure. This was his X-ray. Initially not terribly bad. You can see just mild lower lobe infiltration, particularly on the left side. And then it got worse gradually until he developed respiratory failure. And this was his CT scan showing airspace disease, subpleural mainly, airspace disease and ground glass infiltration throughout both lungs. After that case, this case was announced officially, was reported officially to the WHO in September. That patient who died in June was notified officially to the WHO in September. Just a few days after this announcement by the WHO, a Qatari man who was 49-year-old, who had traveled to Saudi from the 31st of July to the 18th of August, 2012, was admitted with acute pneumonia. This is for slides? I'll use the... So the patient was hospitalized in Doha on the 9th of September. He deteriorated and he was transferred to London. In London, they investigated this man with this severe odd pneumonia, and they couldn't reach to any diagnosis. And then they heard about the announcement of the WHO about the patient who was diagnosed in Jeddah with a new virus. So they sent the WHO specimens from this patient, and it was confirmed to be another case of this novel coronavirus, now known as MERS-Corona. This patient fully recovered, alhamdulillah. And then a third case happened. I'm just describing how the outbreak started because of few lessons that we should learn from it. A 45-year-old Saudi was hospitalized in the 12th of October with severe respiratory illness as well. He was a heavy smoker with a number of underlying comorbidities. Over the next few days, he deteriorated, and eventually he required mechanical ventilation and hemodialysis. this patient gradually improved and eventually recovered. The fourth case was a 70-year-old man in Riyadh. So different regions now, Jeddah, Riyadh, had respiratory illness. MERS-Corona was confirmed, and this patient died. But what was interesting in this patient is that he infected 2 of his sons. One of them also died. Then an interesting outbreak was diagnosed. In الزرقاء General Hospital, مستشفى الزرقاء العام في الزرقاء في الأردن, had an outbreak of severe respiratory illness among 13 patients back in April 2012. So this was at least 2 months before our first case. 11 of the 13 were healthcare workers in الزرقاء Hospital, and 2 of them died. At that time, the Jordanian government sent specimens to the WHO because they said, well, we could not explain why this outbreak happened. The WHO at that time could not reach to any diagnosis. They thought that this was idiopathic or unexplained pneumonia. And then, interestingly, when Saudi announced the discovery of this virus, the WHO retrieved the samples that were sent to them from Jordan earlier that year and examined them for MERS-Corona, and it was found to be MERS-Corona positive. So that outbreak that happened in Jordan 2 months, at least 2 months before our patient, was caused by MERS-Corona. So actually it first then appeared in Jordan. But according to the published study on this, the first case that ignited the whole process apparently did not visit Jeddah, apparently. So they say that he had no relation to Jeddah or Saudi. So it happened in Jordan. But I doubt it very much. I think because most of the subsequent cases that happened in the world had a link to Saudi or the Gulf countries. Another family cluster happened in UK. A Pakistani man, briefly, a Pakistani man who came for Umrah, and then 4 days before he left back to London, he had upper symptoms, and then when he went there, he got sicker, was admitted, received ECMO, extracorporeal membrane oxygenation, but died. The UK government did an extensive work on this patient just to see how the behavior of this infection is. So I'll give you some details of what happened. 6 of this patient, this Pakistani patient who died, Allah yarhamu, 6 of his household contacts developed acute respiratory symptoms in the 10 days after the last exposure. So 20 had contacts, 20 were household contacts. 6 of them developed simple infection. Simple infection. 1 of them was confirmed, and 5 were not confirmed. Okay? So this shows you a few things. That the infectiousness is not simple. It's not easy. I mean, it's not easy to transmit MERS-Corona from one person to another. 20 household contacts, only 6 of them got sick. And among these 6, only 1 had severe infection. The other 5 had simple or self-limited infection. The other thing is that you can miss the diagnosis by doing the new technology with the PCR or whatever, because 5 of the 6 had negative results, even though they likely had the same viral infection. The 1 of 13 non-household contacts, he had visitors who came to visit him in the hospital. 1 of the 13 developed an acute mild respiratory illness, and MERS-CoV coronavirus and also type 2 parainfluenza virus were detected in her specimen. This case was his daughter who came from a distant site to visit him, and she got infected when she visited him in the hospital. But luckily, she survived. The first one, the household contact who died, who actually got MERS, died. And he had an underlying leukemia or underlying malignancy. 7 of 59 healthcare workers who had contact with the patient without full PPE, 7 of the 59 of nurses and doctors in UK who had contact with this Pakistani man without wearing high filtration mask, visors, gown and gloves, 7 of them got ill. And they had mild, self-limited respiratory infection in the 10 days after the last contact. All of those who had symptoms, the self-limited symptoms, tested negative for MERS-Corona. So they might well have had MERS-Corona, but again, the test was negative. So it seems that the test is positive only when you have severe cases of MERS-Corona involving the lung. But when you have just common cold or coryza, the test is usually expected to be negative. 2 of 11 UK-based passengers who flew with the patient on the airplane from Jeddah to UK were reported to have respiratory symptom. 2 of them. One had recovered by the time the study was done, and the other one was not detected from his secretions. So this again shows you the transmission in the airplane was really very weak. 2 only out of 11 very close contact in the airplane had symptoms, and one of them who had the symptoms was tested and was tested negative. Another interesting outbreak happened في الأحساء in the Saudi. We had 22 patients, including 10 deaths. And this was actually the biggest outbreak in a healthcare facility that time. And we may have another one now in other facilities. That hospital was a private hospital, and outbreak investigation was done and published. But you could not really reach to conclusions as to why this outbreak happened. In Tunisia, another outbreak happened, but I'm not going in details on this. In Italy, another cluster happened. But all of them, the ones in Tunisia and Italy, were related to people. The Tunisian one from a pilgrim coming back from Jeddah, and the Italian one was in a patient coming back from Jordan. This is the total number of MERS-Corona confirmed and reported to the Ministry of Health until today. We have 231 cases from the time it was discovered in September 2012. 76 of them died. So the mortality now is 32%. It used to be about 55%, but now as we diagnose the disease earlier, and we have now many hospitals that can send specimens to the Ministry of Health and check even simple infections. So we're now diagnosing mild infections of MERS-Corona. As a result, the mortality has declined to 32.9%. I expect the mortality to be even much less than this, And the MERS-Corona has a wide, in my opinion, has a wide spectrum of presentation. And maybe less than 10% of patients develop the full-blown MERS syndrome. And maybe 90% go undetected or go undiagnosed. The rest of the world reported 37 cases, 22 died, for a mortality of 59%. So overall, in the world, we have 268 patients, تقريباً 98 died, and the mortality is roughly 37%. Now, we've recently admitted 5 patients, King Abdulaziz University Hospital. One of them, the first one, which is this one, presented to us very late. He was seen in so many other hospitals, and the diagnosis was missed. And then he presented to us with respiratory failure, was immediately admitted to the intensive care unit. And this is his story. He was 44-year-old, retired military man, who presented on the 3rd of November with 8 days history of fever, cough, and runny nose, and 3 days history of progressive shortness of breath. And this is really a warning sign. When somebody has upper respiratory symptoms and then develop shortness of breath, this is a very serious warning sign. The upper symptoms are not to worry about, but once somebody who has cold develop shortness of breath, you must immediately go to a doctor because it can be MERS-Corona. This patient had 3 days of shortness of breath but was roaming around. Nobody picked him up. And then he presented to us in our ER, the diagnosis was made, suspected, even though it was the first case. So the diagnosis of MERS-Corona was immediately, initially his saturation was 88%, tried BiPAP, failed, so he was intubated. His white count was 4.9 on the lower side, and he was lymphopenic. His hemoglobin was 15, platelets 162. His electrolytes were normal, CK was slightly elevated, and LDH was elevated. This is his X-ray when he presented. So already bad pneumonia up to the mid-zones. He deteriorated. This is a CT scan showing characteristic subpleural ground glass infiltration. Okay. I thank Dr. Amr Ajlan for his excellent report. You can see the infiltration. It is characteristic. Yani the infiltration is peripheral, subpleural, which is typical. And even on chest X-ray, I'll show you X-rays with typical peripherally located infiltration. This is his lower lobes, fully consolidated. And this is just on day 9. You can see that his lungs just became wide. And this is just before his death. He died 15 days after admission. And interestingly, we, Dr. Isam Azhar and his group, we took samples from this patient on a daily basis to see whether he continues to shed the virus until his death. And he did indeed shed the virus. Until he died, he was still positive for MERS-Corona. So 15 days after admission and 22 days after the onset. This was case number 2, who was a 27-year-old plastic surgery resident who was working in another hospital. He was well until 12 days. And this case is really interesting because of the atypical presentation. He was well until 12 days before presentation when he began to have lethargy and generalized body aches and back pain. No sore throat, no runny nose, not even cough. So he presented with just body aches and lethargy. 3 days later, he started to have fever and cough. And 7 days later, he was brought to the ER because of worsening of his shortness of breath. So even though it started with systemic illness, he eventually developed shortness of breath. He had no recent travel or contact with animals. This was his exam. He was desaturating 90 to 92%. He had signs of consolidation with bronchial breathing and dull percussion note in the right lower lobe. So this pneumonia can give you signs on physical exam. It's not like the other atypical pneumonia where you may not detect any signs on physical exam. He had leukopenia and he had thrombocytopenia. Maybe I forgot to add the platelet count, but his platelet count, it was around 70 or so. So he had both leukopenia and thrombocytopenia. With this body aches and pains, one would think of dengue. So he presented with dengue-like syndrome, but then with pneumonia. So initially we thought, well, MERS-Corona is possible, but dengue with pneumonia is a known complication. So we labeled him as possible dengue with pneumonia versus MERS-Corona or H1N1. And to our surprise, he was confirmed to have MERS-Corona, even though his presentation was not typical of MERS-Corona. He was admitted, he was in the medical floor. He To make things worse, he developed grand mal fit after taking tramadol injection. And I thought that this was just seizure induced by tramadol, and he did not have evidence of encephalitis confirmed by lumbar puncture. He was transferred to the ICU, did not need intubation. He was treated conservatively with 10 to 15 liters of oxygen per minute, and then he gradually improved, and he was discharged 15 days after admission in good health, and he's now recovering from his acute illness. He was really very sick. You can see his X-ray when he presented. He just had this right lower lobe consolidation. You can see it on the lateral film as well. Then his pneumonia got worse. See, his pneumonia got worse, both sides getting worse. So just within 4 days, see, this is day 4. Just within 4 days, you have almost complete whitening of his lungs. And this shows you how rapidly the pneumonia may progress in patients with MERS-Corona once it reaches to the lung. This was his CT scan on day 5, showing the ground glass infiltration. This was his X-ray before discharge. So markedly improved. And he's now, alhamdulillah, in good health. The third case we had was discharged as well, a 34-year-old, previously healthy military man, heavy smoker though. He presented with 7 days history of fever, malaise, arthralgia, headache, nausea, vomiting, and decreased appetite without upper respiratory tract symptoms. Again, this is another interesting case, presenting with mainly GI symptoms and systemic illness without upper symptoms. He had no diarrhea or abdominal or chest pain. He lives في الحرزات, and he had no contact with animals. This was his X-ray when he presented, showing bilateral. As you can see, it is peripherally located. You can see the infiltration, peripherally located. And this patient gradually worsened and desaturated, but he was treated conservatively with oxygen supplements. He fully recovered, and he was discharged on the 14th of April, 11 days after admission in good health. As you can see, this patient whom I just described, had leukopenia. Okay, and he also had thrombocytopenia of 96. So again, leukopenia and thrombocytopenia are cardinal features of MERS-Corona in the cases that we've seen. This is his day 4 X-ray. You can see it progressed. And then he eventually, alhamdulillah, recovered. The 4th case was a previously healthy Saudi man, lives for Ruwais, heavy smoker again, presented to the ER with 2 weeks history of fever, up to 39, with dry cough. So this one did have respiratory symptoms. But his cough was not preceded by any coryza, any rhinorrhea, or any sore throat. He had relative bradycardia, and otherwise there was nothing impressive, few bilateral basal crepitations. This was his X-ray, pleural-based infiltration on both sides. It's predominantly basal pneumonia that extends up, particularly the periphery. Very typical and very interesting pattern. This was his subsequent X-rays, getting worse. But alhamdulillah, he's improving. He's still in the hospital. He's improving. Actually, he felt well enough to abscond. He absconded from the hospital, but then his family brought him back. Luckily, when he absconded, his tests were negative. And he's still in our hospital, about to be discharged very soon. The 5th and last one was a 57-year-old, also a cigarette smoker, who presented with 12 days history. As you can see, the history is usually not very acute. Most of them present with a week to 2 of symptoms. Fever up to 39, headache, cough, and blood-tinged sputum, and generalized body aches. He lives in Al-Balad with no recent travel or contact with sick patients or animals. This was his X-ray. As you can see, peripherally located infiltration. This patient was shifted to the ICU because he deteriorated, desaturated, but alhamdulillah, he eventually recovered. Now he's moved back to the isolation unit, and he's recovering from his illness. This is his X-ray when he deteriorated, as you can see, but he's improving. So these are the 5 cases that we've had in our hospital. The first one died because he presented late. The other 4 ones, alhamdulillah, they recovered, even though they deteriorated in our hospital because of the natural progression of the MERS-Corona. But alhamdulillah, with the supportive care and the good ICU care that we have, alhamdulillah, all of them recovered, fadlullah subhanahu wa ta'ala. Now, very important question, where is this virus coming from? What's the origin of this virus? Is it like the other coronaviruses of zoonotic origin, originating from animals? Is it in bats? Is it in rats? Where is it coming from? Has it been circulating before it appeared? Was there any evidence of this virus in the world before it appeared? These were questions that scientists tried to answer. One of the earliest studies that were done was in Europe. They examined 1,800 samples, serum from patients and healthy people. And they looked for antibodies against MERS-Corona. And to their surprise, they found no single person in this cohort of 1,800 person had antibodies against MERS-Corona, indicating that this MERS-Corona is brand new, is really novel. Was never circulating in the world before it appeared. Analysis of short genomic sequences indicated that MERS coronavirus might have an ancestor in bats. They isolated or they used primers to identify short sequences of coronaviruses in bats, and they found that these short sequences are identical to the MERS corona. So many scientists now believe that bats, the khafafish, الوطاويط, are reservoirs of MERS corona. But this hasn't yet been confirmed. This is just a picture of the possible bats that can be reservoirs of the MERS corona. This is called the lesser bamboo bat, or Talonecterus pachypus. Okay. It looks big, but this is only 15 centimeter wide. It's very small, 15 centimeter wide. This is how it looks like at night. This is another species that is also present in the kingdom. Both of these bat species are present in the kingdom. This is another one, Pipistrellus, which is also believed to be reservoir for this MERS corona. The Ministry of Health did extensive study to search for strong evidence that bats are indeed reservoirs. And they captured bats from all over the kingdom, and they isolated from one bat, this species, Typhosus perforatus. They isolated, not isolated, sorry, they identified using PCR a short sequence that was identical to the human MERS corona. So this was strong evidence that bats may indeed be reservoirs of the MERS corona in the kingdom. However, most of our patients who got infected had no relation to bats. They didn't even see a bat in their life. None of them, or almost no. So how would the bats transmit the infection to humans? So we all believe that bats may indeed be reservoirs, but they transmit the virus to the humans through an intermediate host. That intermediate host now is under intense investigation. And we try to help in doing investigations to reach to this conclusion. Evidence suggested that camels could be the intermediate host. And the suggestion came from the fact that serology of camels, they collected blood from camels from Oman, Egypt, or Canary Island in Spain. they found that 100% of the camels in Oman and 14% of the camels, dromedary camels, in Spain had antibodies specific against MERS-CoV. So this was a clue that camels could actually be intermediate hosts or even reservoirs. We don't really know yet until that point. This is the so-called dromedary camels. It's the one-humped camel, as opposed to the bacterian camel. This one has nothing to do with MERS-CoV. The evidence suggests that the Arabic camel, الجمل العربي أو يسموه dromedary camel, is possibly the one that is infected with the MERS-CoV, or reservoir of the MERS-CoV, or the intermediate host. Another serological study in Egypt found that they took samples from 110 camels in Egypt, and they found that تقريبا من 93 to 98, depending on the antigen that they detected, were positive. So more than 90% of the Egyptian camels had antibodies against MERS-CoV. Okay? And this was really also interesting to know. They tested other camels. Few studies, they checked the cows, the sheep, goats, and they found no antibodies in these other livestock animals. So it seems that camels in particular have the ability to get infected and maybe to spread the infection to humans. This was all speculations and was based on serological study. Until, alhamdulillah, in the university, in our university, and our colleague, Dr. Isam Azhar, who will be talking to us next, and his group, Dr. Anwar, Dr. Sharif, Ahmed, we have really excellent research group in the research center. We actually found the first conclusive evidence that camels are definitely sources of infection to humans. And what happened is that the first case that presented to us, who was really very sick with bad pneumonia, that person was interviewed, the family of that person were interviewed by us, and we asked whether that patient had any animals. They said yes, he did have camels. He had 9 camels that were kept in a pen, even 70 kilometers far from Jeddah in the south towards Al-Khumra, War Al-Khumra. So we immediately, I asked my colleague, dear eminent virologist, Prophet Tayyib Abu Zain, who is an excellent veterinarian and eminent virologist, working with us in the scientific chair for viral hemorrhagic fever. I asked him to send a team, our team, veterinarian group, to collect samples from camels. So they did collect, and Dr. Isam also was involved in coordinating this work. They sent a team, collected samples from the nose and secretions of the camels, from the blood, from milk and stool and urine. And interestingly, we isolated a virus from one of the 9 camels. This virus was sequenced with very advanced technology. Dr. Isam Azhar and his group, the research lab, it was sequenced. The full genome of the virus was sequenced. It's not just part, the full genome. And we also managed to isolate the virus from المريض الله يرحمه in our ICU. So both viruses were, بفضل الله, isolated. And this was the first time, by the way, it gets isolated after the isolate in a private hospital. No one else in the kingdom has this isolate. The isolate was sequenced, and interestingly, it was 100% identical to the human isolate. So the camel isolate was 100% identical to the human isolate. يعني زي بصمة طبق الأصل. So there was definite transmission between the human being and the camel. Now one could ask, which one happened first? Is it the human who infected the camel, or the camel that infected the human? It could be either way. Like, alhamdulillah, we managed, by doing our research, we managed to answer this question. The samples that we took from the patient, blood samples that we took from the patient, were initially negative for antibodies against the MERS-CoV. Whereas the samples taken from the camels had very high titers against MERS-CoV. indicating that the camels got infected before the human being. So this was a clear evidence, along with the viral isolate and sequencing, that actually camels were the source of infection of this patient who died with MERS corona. This is the pen that was sampled. These are the camels. He had 9 camels. All of them were sampled. And we managed to confirm that the camels were infected. All 9 camels had high antibodies against the MERS corona. And one of them had an active shedding of the virus that was isolated, as I said. We did phylogenetic tree. Maybe Assam will talk about this in more detail. And we compared our isolate with the other isolates in the world, and it was very closely related to them. So this is the animal isolate and the human isolate. They were identical, and very similar to the MERS corona isolates that were reported in the gene bank elsewhere. So just to talk briefly about the symptoms of MERS corona. Now we talked about the possible origin of MERS corona. One important thing that we have to clarify. When I said in several occasions that camels could transmit the infection to humans, people did not understand this statement. People thought that I'm claiming that camels are always the source of infection to humans. And I'm not saying that, and nobody is saying that. Because most of the patients who got infected from other people through person-to-person transmission. So most of the infection that is happening in the community is due to person-to-person transmission. But the index cases that ignited the process in the different outbreaks could have acquired the infection from camels. For example, the outbreak that happened, the one كلكم يعرفوا الله يرحمه, the nurse who died في مستشفى الملك العزيز. I heard that the patient from whom he acquired the infection came from a place. I'll not say that name for people to panic. He came from a place where camels are very commonly used. And the outbreak that's happening in another center also happening after a case from that also place where camels are common have been seen in the hospital. So it starts, maybe the first case could have acquired it from camels, but then once it goes to the hospital, when people are not taking precautions, then that case may spread the infection to other people, and people may spread it to other ones. So camels then could be the reservoir. We have to be very careful, but we should also know that the main mode of transmission is actually from human to human these days. So the symptoms include cough, sore throat, runny nose, nasal congestion, headache, low-grade fever, facial pressure, and sneezing. Often pneumonia, ARDS, renal failure, pericarditis, and DIC. This is how the CDC defines the MERS corona. They define it for them. This is used by them. They say a patient, they classify them into a patient under investigation and into confirmed cases and probable case. Patients under investigation or suspected, suspected patients, is a person with the following characteristics. This is when you should suspect MERS corona. If you were in the States. Fever of more than 38, and pneumonia or acute respiratory distress syndrome on clinical or radiological evidence, and either history of travel from countries, طبعا نحن المين country that the American referred to, history of travel from countries in or near the Arabian Peninsula within 14 days before symptom onset, or close contact with a symptomatic traveler who developed fever and acute respiratory illness, not necessarily pneumonia, within 14 days after traveling from countries in or near the Arabian Peninsula, or if the person is a member of a cluster of patients with severe acute respiratory illness, example fever and pneumonia acquired requiring hospitalization of unknown etiology, in which MERS corona is being evaluated. So some of them are not applicable because now we're in the midst of this increased number of cases. Anyone with upper symptoms and pneumonia, now this is the message that I want you to go out with. Anyone with upper symptoms, fever, acute febrile illness, cough, or dengue-like symptoms with pneumonic infiltration should be suspected as MERS-Corona. Even if it is lobar consolidation, even if it looks typical of lobar pneumonia or pneumococcal pneumonia. Anyone with pneumonia in these days, because now we're having a lot of cases. So in the community, not alhamdulillah in our hospital. The confirmed cases is considered to be a person with lab confirmation of MERS-Corona, and Isam will talk about this in a short while. The probable case is anyone under investigation with absent or inconclusive lab results for MERS-Corona. So if you have a patient with typical MERS-Corona, pneumonic infiltration that is peripheral, etc., and then you find that his PCR is negative, please, this does not exclude MERS-Corona. It can still be MERS-Corona. So don't be lax, don't relax, and don't stop isolating the patient. You should continue isolating the patient and deal with him as possibly infected until he's recovered, even if he's negative. Because many of the patients can be negative. And many of our patients that I was consulted for and that I've seen had actually initially negative results repeatedly, and then it was positive. So negative results does not exclude MERS-Corona in the right context. So how should we protect ourselves? This is really a very core and important point that we have to go over. You've heard of some colleagues who got sick in different hospitals. And when I investigated this, verbally by the phone, I wasn't able to go myself to investigate this, but when I asked them, when I asked the family and their relative how they got infected, and their friends, they said one of them, for example, and the nurse resuscitated a patient with severe pneumonia who was really very sick in the ER. They resuscitated him without wearing PPE, personal protective equipment. They resuscitated him without protecting their mucous membranes or wearing goggles. And they got infected this way. Both of them now are critically ill in the ICU, intubated. Okay? Both of these, nurse and the doctor. So they got infected because they dealt with the patients without really taking the so-called standard precautions. As we always say, please, always follow standard precautions. Always consider any patient as infectious, having an infectious agent. And this is the concept of standard precautions. You don't have to take precautions only for the infectious ones, even for anyone. If you expect to have splashes of fluid into your face, don't assume that these fluids are safe. You have to protect yourself from these fluids by wearing goggles, masks, gloves, and gown. Hand hygiene is extremely important. And I'll talk about the survival of MERS-Corona and influenza virus in the environment in a short while. You have to use PPEs. PPE is abbreviation for personal protective equipment, which means a gown or gloves, mask, and visor, facial shield or goggles. But you wear them, please, you don't wear them all the time, please, because I see people roaming around with masks. And this is not recommended. It is not recommended. You only wear a mask when you come in close contact with a patient, or when you expect to deal with a patient with MERS-Corona. Then you have to wear the appropriate mask. If it is just respiratory illness that could be anything, then a surgical mask would be fine until you assess your patient. But once you feel that the patient may have MERS-Corona, we recommend in this hospital, as well as in the CDC, they recommend high filtration mask, a N95 mask, when you deal with MERS-Corona case, or H1N1 case, or SARS, la samah Allah. The Ministry of Health recommends droplet precautions. So they recommend regular mask. And the WHO actually also recommends what the Ministry of Health is recommending, regular mask. But I think, in my opinion, high filtration mask and negative pressure rooms should be used, not neutral rooms as recommended by the WHO. طبعا WHO is basing their recommendations on the Ministry of Health recommendations. They don't have their own, inventions. But this I'm sure the WHO will change their recommendations very soon to airborne precautions. The SARS initially was thought to be a droplet infection, but then it turned out to be airborne. When providing care in close contact with a patient with respiratory symptoms, example somebody who's sneezing or coughing, you have to use eye protection because droplets into your eyes may transmit infectious agents, including MERS, HIV, etc. We conducted a study by Prof. Oxford and other international authors to see the survival of H1N1, which is another headache that we're having. And actually, we have more cases of H1N1 than MERS-Corona. We conducted a study where we looked at the survival of H1N1 on surfaces. We took wooden chopping boards, اللي هي قطاعة الخشب, stainless steel sheets, والبلاستيك toy ducks, لعب الأطفال, والcotton pillowcase, أكياس المخدات. And we inoculated them with H1N1 virus. And we took samples from these areas at different time points, and we found that H1N1 survived for 48 hours on the wooden chopping boards. The virus was infectious up to 48 hours on wooden boards. And this table would be infectious if somebody with H1N1 coughed or sneezed. It will be infectious for up to 48 hours. If you touched it, you can get it. This shows you how important it is to wash your hands and disinfect your hands whenever you touch any surface. Very, very important. On stainless steel sheets, it stayed up to 24 hours. Also on plastic toy ducks, up to 24 hours. On cloth, on pillowcase or cloth, it can remain up to 8 hours. Another study that was just sent to me by Zamila Ahmed Al-Jahani, recently published, and did also survival of MERS-Corona. Similar to the study that we conducted, they looked at MERS-Corona at different temperature and at different humidity. When the humidity is like the room humidity, 40%, and the temperature is like the room temperature, 20 degrees, the virus survived for 48 hours. So at this temperature, in this auditorium, for example, this is very conducive for the virus to survive for 48 hours. If it is too hot, the virus survival will decrease. If it is too humid, if the humidity is high, the viral survival will decrease even further. So the higher the humidity and the higher the temperature, the better, or the less survival of the virus. So this shows you that the virus can survive in our humidity and temperature that we have in our houses and our classes and our auditorium, etc., which is really serious, 48 hours, up to 48 hours. So you really have to be careful with hand washing and the... Now, after the H1N1 outbreak, the SARS outbreak, the CDC and the WHO proposed respiratory hygiene or cough etiquette. Respiratory hygiene or cough etiquette. This is a very important principle. They are standard precautions, and this is part of the standard precautions. It is meant to prevent transmission of respiratory infections at the first point of contact within a healthcare setting. Reception, triage areas, ER, OPD. يعني أحيانا we see a lot of patients في الER sitting between patients coughing and sneezing. ولا في العيادة جالس في العيادة في waiting area coughing and sneezing. This is very dangerous. The SARS outbreak happened from such patients who were coughing in the waiting areas, infecting everybody. So they developed this so-called respiratory etiquette. Simple thing, common sense, ما في شيء يعني غريب, but we have to do it. The elements, and you have to educate both the healthcare facility staff, patients and visitors on what to do to prevent respiratory infection. Very important. You have to put signs on how to protect others from infections and to protect yourself as well. in different languages, not only in English or Arabic. Sometimes you have to write it in Urdu, in Filipino, in Indonesian. You really have to use as many languages as appropriate. The source control measures, very important, source control measures. You have to educate the patients and the staff to cover the mouth and the nose during coughing or sneezing with a medical mask. So if somebody goes to the ER, the receptionist should ask him, do you have any cough, any sore throat, any fever, any runny nose? If he says yes, you should give him a mask to wear immediately. So you're trying to contain the virus in the patient himself so that it doesn't spread to others. So the patient himself has to wear a mask. If the patient was not masked and wants to cough, then he should cough not on the hands but on the elbow if he doesn't have accessible tissue. So making tissues available in the ER and the waiting areas is also very important so that patients use them to sneeze and cough. And they should dispose of the tissues right away in the garbage. Hand hygiene is also very important. After coughing or sneezing, the patient and the healthcare worker should disinfect the hand with alcohol. And the alcohol should be made also in the waiting areas, في الطوارئ and waiting area in the hospital. Spatial separation is another part of the respiratory etiquette. يعني for patients who have respiratory symptoms, they should be kept in an area where seating is at least 1 meter apart. Better 1.2 meter between the chair and the next. They should not be overcrowded. And I heard that the outbreak that happened in one of the near hospitals happened because the emergency room was just overcrowded. People were almost above each other, just close to each other. Very, very dangerous practice. The minimum distance between a patient and the other should be the standard, should be 1.2 meter. Anything less than that will spread infections. The recommendations when you have somebody with suspected corona is to keep them under airborne and contact. Under airborne and contact. But as I said, Ministry of Health recommends droplet and contact. And maybe droplet alone, I'm not sure. But please, in our hospital, as well as in the States and most Europe and other developed countries, we use airborne precautions and contact, not only droplets. So you have to admit your patients in a negative pressure room, not neutral room, not neutral pressure room. If you don't have a negative pressure room, in our hospital we have HEPA filters, portable HEPA filters that we made available, and Zallah Khair, Prof. Mahmoud Ams supported us, and we were planning to get 10 more. We have 8, and we're planning to get 10 more just to deal with any possible increase in the number of cases. Now, anyone with suspected MERS corona, for whom we don't have a negative pressure room, you can keep him in a single room, but you have to put this portable HEPA filter near his head. The room has to be negative pressure. When you go into this room, you have to wear a high filtration mask, high filtration N95 mask when you go into a negative pressure room. It has to be fit tested, and we will be doing the fit test very soon. We did it for the isolation staff, for some of the isolation staff, but we are planning to do it for all hospital staff. Fit test means we have to make sure that the N95 mask is well fitted into your face so that it doesn't lead to any leakage. And this is done by wearing a hood and spraying certain chemicals. If you were able to smell it or taste it, معناها the mask was not well fitted. So we'll be doing this. We're opening now a clinic to do the fit test for the N95 mask. You should also wear gloves and gown and goggles or face shield when you're dealing with patient secretions, مثلا for resuscitation, or when you're setting, say, a central line, or whenever you expect splashes of fluid, or delivering, say, a woman. When you're anticipating splashes of fluid, you should wear these person protective equipments. طبعا when you exit, please, when you go out of the room, don't keep the mask on your face. it is not recommended to roam around with mask. Please, I say it again. Not recommended to roam around. You're actually exposing yourself to infection before anyone else. This mask that you're wearing could be a source of infection to yourself. If you kept it too long, it will collect germs and becomes ineffective. And actually, it can be a source of infection to yourself and to others. When you remove it after being contaminated, you can contaminate your hands and you can infect your family and others. So it is not recommended to wear a mask all the time. But you should wear it only when you go in to see a patient or when necessary. If it is a high filtration mask, you can reuse it. According to the international recommendations, high filtration mask is difficult to get. في shortage in the world, but then it is expensive. Each mask may cost about 10 ريال. الماسك الواحد ال N95 mask. So it is recommended by the Shia and the CDC that you can reuse the mask for up to 8 hours continuously. If you had to wear it 10 minutes for each patient, the cumulative duration can be up to 8 hours. Then you have to change it. Unless it broke or it was torn, then you should change it. But don't keep it on the floor, on the wall, I mean, or the desk. You have to put it in a plastic bag and put your name on it. And keep it in your pocket or keep it in the wall. When you have to go back, you can reuse it again. But make sure that your name is on it so that it doesn't get mixed with other ones. If you're a patient with MERS-COV or with, say, TB, pulmonary TB, or H1N1, has to go to the radiology for a test, or has to go for an intervention in the OR, or whatever, you must keep a mask on the patient. Regular mask, not high filtration mask, regular mask. Regular mask would be okay for the patient, but high filtration mask is for you. If you kept a high filtration mask on the patient, he will suffocate because it is difficult to breathe through a high filtration mask. Transportation of patients should be minimized. Somebody who's in the ICU, critically ill, he doesn't really need to have a CT scan to confirm whatever, if it is not that really essential. So minimize transportation as much as possible, because the more you transport the patients to other units, the more spread it may go. Staffing should also be trained and should be minimized. Staff dealing with MERS-CoV patients have to be well trained and have to know how to take precautions. And it is better to dedicate certain staff for the infected cases so that you don't spread it among all other nurses or all other staff. A few words, just 2 more slides, and then I'll be done. There is no specific antiviral agent. There is no specific antiviral therapy. The treatment is mainly supportive care. So if the patient needs ventilation or fluids or etc. There have been many experimental treatments. The best of them that has moderate evidence that it may work, taking plasma or blood donation from somebody who survived MERS-CoV. You take his plasma and give it to an acutely ill patient. The plasma of a convalescent or somebody who recovered from MERS-CoV may have neutralizing antibodies. And there is evidence in animals and also in some limited human studies showing that actually taking plasma from an infected patient, giving it to an acutely ill patient may actually improve the outcome. This is the only one that has really moderate evidence. The rest, intravenous immunoglobulins, interferon, HIV protease inhibitors, ribavirin, corticosteroids, nitazoxanide, cyclosporin A, combination therapies, etc. They've tried all of these, and the evidence for them is still not solid, or actually very weak. Most of them is very weak. So if you want to use interferon or ribavirin, as recommended by other sectors, it has to be part of a study. You cannot just give it as a standard protocol. It is not really recommended. طيب, last thing, أفضل وقاية, as we all know as Muslims, الحمد لله have the best وقاية. عارفين الحديث عن عبد الله بن خبيب رضي الله عنه قال قال رسول الله صلى الله عليه وسلم اقرأ قل هو الله أحد والمعوذتين، اللي يقول أعوذ برب الفلق قل أعوذ برب الناس 3 مرات تكفيك من كل شيء، يعني تحميك من كل شيء. والحديث الثاني العظيم عن عثمان بن عفان رضي الله عنه قال قال رسول الله صلى الله عليه وسلم ما من عبد يقول في صباح كل يوم ومساء كل ليلة بسم الله الذي لا يضر مع اسمه شيء في الأرض ولا في السماء وهو السميع العليم 3 مرات إلا لم يضره شيء. قال 3 مرات الصبح 3 مرات المساء. And you can see anyone even with MERS corona. Thank you very much. Okay. Any questions? Yeah. Do we have more mobile phone? طيب خليها أول.
Actual corona cases, we are doing only once the swab for them. In the future, are we going to continue like that? You told us most of the cases initially they were negative and then they became positive. What about our staff?
That is asking whether we need to take swabs from contacts. We did take swabs from contacts, healthcare workers who had contacts with our MERS corona cases, and we screened 98 staff. All of them were negative, alhamdulillah. We don't need to repeat it unless the staff has become symptomatic, la samah Allah, then we have to do it. I was talking about patients. Patients with symptoms may have actually negative, false negative results. So you don't really have to believe it if clinically compatible with MERS corona. No need to repeat. Yes. But it has to be done, by the way, if you want to screen a staff, for example, if you had MERS corona now in the ER, you should not come to me and say, well, I want to get swabbed. أولا, you have to fulfill certain criteria. أولا, the exposure has to be unprotected. يعني staff إذا بالغلط was exposed to a patient without PPEs. This should be screened. أما إذا staff لابس الماسك والgloves والgoggles ما يجي يقول سوي لي screening. لأنه هذا protected exposure. الستاف اللي كانوا واخدين احتياطاتهم من البداية should not ask for screening. They will not be screened. شيء ثاني, they have to wait at least 2 to 3 days after the unprotected exposure. 2 to 3 days after the unprotected exposure to be swabbed. لأنه it is very unlikely to get the virus right after the exposure. So you let the virus to replicate for 2 days or so, and then you try to pick it up with a screening test.
Yes. Thanks, Doctor.
Of course, طبعا all unprotected exposures have to be followed, and we do that in the healthcare, in the staff health clinic. طيب. And the Minister of Health, he's asking whether we will issue recommendations on how to control SARS. And this is the Minister of Health responsibility. We don't have the authority to release any recommendations unless we're part of a committee in the Minister of Health. The Minister of Health is leading the control. We're not entitled to do that. We, of course, can give advice. If they ask for our help, we'll definitely help. Lakin we're not entitled to go and say, well, we recommend that and that for people. But we do release recommendations for our own staff. هذه ما في مشكلة. But we cannot just release it to the rest of the kingdom, saying that this is King Abdulaziz's recommendations. It won't be nice. They will not like it.
I think the most important thing is the awareness. Such program would alert the people, especially as healthcare workers. I mean, I come across, so many individuals or so many healthcare workers, they were handling infected patients without taking any personal protective clothes measure or standard precautions as mentioned in Dr. Tariq lectures. But this is really important. I mean, sometimes it's not, something that need to be generalized from the university to the others. In the same institute, in the same hospitals, you have to admit and you have to work with all these, different precautions. In our facilities as well, we are concerned with the laboratory-acquired infections. That's why we are taking, what they call it, infection control measures within our lab facilities to be able to prevent, our colleagues to encounter any infections, because we are dealing with all these positive samples. So we are having a biosafety level 3 labs, and unfortunately, I came across as well as some other hospitals, private hospitals, where in their ER, they don't have any separate room or isolation rooms, if you like, which makes it really difficult to spread the infections. But in our hospitals here, we have, a separate room, dedicated, isolated rooms in ER, and in the isolation ward as well, which makes it really important. We went around to collect some samples, environmental samples from these different hospitals, and we have seen all these people. So at the end of the day, awareness is really important when you are handling or dealing with all these infected materials or patients.
If طبعا all of them, if you have a case of open pulmonary TB and MERS-CoV and H1N1, all of them need to be under airborne precautions. However, the best priority is for TB, open pulmonary TB. The next priority is for MERS-CoV, simply because the transmission of MERS-CoV has not yet been proven to be airborne, but we're taking the cautious side. But TB, it is definitely airborne. We cannot play with TB. So patients with TB should get priority over MERS-CoV. MERS-CoV patients, if you don't have rooms for them, you can keep them in single room with a portable HEPA filter.
Excuse me, doctor. Yes, me. Since the symptoms of corona are mild, and we're basically seeing patients every day with mild flu symptoms, can we get infected through get in contact with them? And should we take these precautions with these patients with mild flu symptoms? And the other question is, can we be carriers? For example, we're walking around in the hospital. Can we be carriers to outside the hospital? That's my question.
Very good questions. Very important and really good question. Should we take precautions with anyone who's coughing or having coryza? Yes, we definitely have. Consider anyone with coryza as possible MERS. So you have to wear a regular mask though, not high filtration. A regular mask, examine your patient. If the patient is coughing and waiting in the waiting area, you should put a mask on the patient, ask him to wear a mask. And I always do that in the clinic, even before the MERS. Whenever we get a patient who's coughing, we give him a mask, ask him to wear a mask. And even if the woman is محجبة or wearing a veil, المرأة المحجبة should not put the mask on top of her veil. Although it will not protect her. It has to be under her veil. And then she can put the veil over it. But the mask has to be adjacent to the face, not above the veil. Can we be carriers? Until now, we haven't proven that the virus is carried in our staff. We had some staff who were exposed to MERS-CoV. We screened them, and none of them was positive. But according to the Ministry of Health unofficial information given to us by the group who came and visited us last week, Dr. Mohammed Khisham told me that they had 28 cases of MERS-CoV. 14 of them were asymptomatic. But this has not been officially given to us or published. This is what he said. So the fact that they were asymptomatic means that they people may carry the virus without having symptoms. And can they spread it to others? Possibly, yes. Definitely, if you carry an infectious agent, you can always carry it to somebody else. لكن حقيقة, I don't think that this is playing a role in the community because, as we said, I showed you several examples of how weak the virus is transmitted from person to person. Out of hundreds in the UK, only 2 got infected, even though the patients were very sick. من باب أولى, those with very mild infection will be infectious. ومن باب أولى, those who are just carriers will be infectious. I don't think that infectiousness is happening from carriers.
Yeah, Prof. Tariq, on the same line, I have a question. We get asked it in the public, very common. When they should come to the hospital? I mean, you know, flu symptoms is very common in public. When they should come to the hospital and they suspect it's...
Excellent question, yes. I get called almost every minute to say my driver has a cold, my mom has something flu, etc. What should I do? Very simple question that people don't know the answer of. And thank you for this. Please, if you have a cold, don't call me. Don't bother me. Please. I have so many things to do. If it is simple cold, don't come to the hospital and don't call me even. But if you get shortness of breath, then you have to come immediately. Also without calling me. Just come to the emergency room and we'll see you in the emergency room. So anyone with shortness of breath and symptoms, they should come. The other thing, if they have severe body aches and lethargy, along with some respiratory symptoms, they should also be evaluated because such patients may have pneumonia. Like the first case or the 2 cases we presented, they just presented with body aches. And then they lately developed some shortness of breath. And both of them turned out to have MERS-CoV. Well, a short answer, even if it is MERS, simple cold, ignore it. You will not need anything. Lakin once it goes down to your chest, causing shortness of breath, or severe symptoms, respiratory symptoms, then you should come to the emergency room.
Dr. Prof. Tariq, can I ask from here? Prof. Tariq.
Sorry.
ايه بروف بس بدي اسال شيء مهم جدا. I'm not sure اذا اي احد اخذ باله من موضوع البلاد دونرز والبلاد دونيشن.
Blood what? Sorry?
Blood donors and blood donation.
Yes.
Now it can be transmitted by blood or not, because this question we were discussing it in the international symposium last June, and they were worried about blood donation and if it is if the blood donor a contact of one person or a diseased patient, and they may transmit this infection, and they may be in the carrier state or they have incubation of this virus. Do we have to get precaution? You remember with SARS we did get precaution. We did have a specific questionnaires in the donor questionnaires, questions in the questionnaires for donor. Yes. I'm thinking to add it actually, but Ministry of Health not yet. So we need to know if we need to get a precaution by adding a question, specific questions to our donor, and the other things maybe by testing our donors while we have this endemicity or whatever. We are not sure it's endemic or not yet, but we have these cases in Jeddah. What do you think about it?
If somebody is febrile and is suspected to have MERS-CoV, he could be viremic. The virus could be in the blood. And the UK government now recommends not only nasopharyngeal swab, and I need to discuss this with Sam. They don't only recommend nasopharyngeal swab or tract secretions. They also recommend blood, urine, and stool for MERS-CoV. So all of these secretions could potentially be infectious. So you should never transfuse blood from a febrile patient with suspected MERS-CoV to somebody who's healthy. It is, as you know, we always exclude patients with fever when they come to
exclude donor with fever, yes. But
so
I think
you will pick them up in your questionnaire if they have
also
fever.
in close contact with patients, they should be excluded. I think we have to concentrate on this.
I'm not sure about this. If you're just a close contact of somebody who had MERS and you are asymptomatic, I don't know whether you should exclude them or not. But maybe to be on the safe side, exclude them for at least 2 weeks.
Yes. For
weeks,
2 or
defer
4
them
weeks.
for 2 weeks.
4 weeks usually with SARS.
Yeah, that's okay. That's reasonable. And to just make sure that they haven't picked up the infection.
Thank you.
Thank you, Dr. Tariq and Dr. Assam, for this excellent awareness. Now, my question, in 2003, during the SARS, the WHO issued guidelines for health workers in the pre-hospital, inpatient, outpatient. Do you think we are at this stage to adopt such guidelines? And if not, when to apply these guidelines?
Guidelines for SARS?
Yeah, like the airborne, during that period when they have that outbreak in Toronto, especially, where they have very clear guidelines what to apply in the pre-hospital, outpatient setting, inpatients, for all the health workers.
Yes, sure. We're doing it actually. Yesterday we met with Dr. Amr Hibshi and Saadat Al-Hamid, and we said that we have to implement our contingency plan for infectious diseases because we're having some increase in the cases in the community. So Dr. Shadi Khayat, for example, has made sure that in the emergency room they have FRI screening, FRI, somebody with fever and respiratory illness. They are isolated, they are given masks, and they have tissues and disinfectants to disinfect their hands. And we also use single rooms for them for assessment. So we're doing it before they come to us. And when they are admitted, we do have negative pressure rooms. We have 36 negative pressure rooms, which is really excellent. حقيقة هذا المستشفى بنيت قبل ما أدري كم 25 سنة أظن ولا 30 سنة. And at that time, people were not aware that negative pressure rooms were important. And they designed and constructed 36 rooms in this hospital من البداية. Now, most of the other hospitals, the new hospitals in other sectors, have no negative pressure rooms. فنحن we're lucky إنه فعلا هذا المستشفى بنيت على أساس صحيح. فنحن we have 36 rooms, 16 منها في الايزوليشن يونت والother 6 الباقي 36 في البيدياتريك وورد في تقريبا 8 السي سي يو we have 1 الجايني فلور we have 1 في الاي سي يوز الميديكال اي سي يوز والسيرجيكال اي سي يوز والان اي سي يو والبي اي سي يو everywhere we have negative pressure room if needed.
I would like to thank, of course, Professor Madni and Dr. Azhar for the nice presentation. Just to make everybody aware about the situation of King Abdulaziz University Hospital, as Professor Madni has mentioned, we have had 5 confirmed cases so far. The first of them died in November 2013, but in the last month we have received 4 patients who were confirmed. 2 of them were treated and they were discharged home. 2 of them are they're still in the hospital, but they are about to be discharged home tomorrow or after tomorrow. There are 12 probable cases that had negative tests, and there are 4 suspected cases, and I believe the results are coming back negative for all 4 of them. Anyhow, the Department of Internal Medicine, with the guidance of the Infection Control Unit, have put all patients under precautions standards as if they are all confirmed. So they are all in isolation, all in negative pressure rooms. Professor Madni has mentioned that we have 36 negative pressure rooms in the hospital. On top of that, we have 4 portable HEPA filters. 8, yes. Actually, the Dean has just met today with the University President, and he approved the purchase of 10 more portable HEPA filters and a lot of needs for needed items for the Corona virus. Our staff, as Professor Madni has mentioned, the health practitioners who were in contact with the positive patients, so far 98 of them were screened and none of them was reported as positive. has acquired the infection from the patients. Other than that, I think just an advice for all the health practitioners just to take the precautions. There is nothing, inshallah, to panic about. The precautions that Professor Madni and Dr. Azhar have mentioned, inshallah, will be enough. We will be watching and monitoring this carefully, just to prevent any rumors from spreading around on the social networks about the university hospital. We will be transparent. We will have a daily report on our website. We will be fed by information and data from the infection control unit, and we will publish them on our website daily about the situation of the patients with MERS coronavirus in the university hospital. Shukran.
Prof. Tariq, I have a question here. What's the incubation period of the coronavirus to get to be symptomatic? And number two, how close contact should be with somebody who's shedding the virus to get the infection? I mean, is it in outdoor, like something like this, a big area? Could it be infective, or like aeroplane? Because they are now. I
cannot understand your second question. Incubation period, and the second question is
how close contact with the index case should be effective? I mean, to spread the virus and to get the infection to other people. Is it, for example, like in closed areas in restaurants or in aeroplane? Because I heard now that they are preventing people, or just I mean, not allowing people to travel outside the kingdom to Europe mainly, unless they are having this certificate that they are negative. Is it true or not? I don't know.
First, for the incubation period, it is not yet well known, but from the patients we've seen in the literature and our own patients, it is estimated to be from 2 days, as early as 2 days after exposure, up to 17 days. CDC يقولوا up to 14 days, but I've seen patients presenting 17 days after the last exposure. So it can range from anywhere from 2 days to 17 days. The other question is, how is the virus transmitted? Does it need?
No, how close contact they need to be? I mean,
how close contact? As I said, now the WHO is adopting what the Ministry of Health is saying, that the infection is droplet. Droplet معناها you have to be within 1.2 meter or 1.5 meters from the patient to get infected. You have to be very close to the patient to get infected. Like in what I'm saying, and what the CDC also is saying, is that it should be dealt with as an airborne infection. Airborne معناها you can get infected by contaminated air, for example. If the room in the air is not separate and has a separate exhaust, it can be a source of infection. Or if somebody was here and coughed, the virus may remain suspended in air and you can get infected even though the person is already out. This is just an extra precautionary measure until we really reach to the exact mode of transmission. We don't want to do the mistake that the world did with the SARS. The SARS, they considered it as droplets, thinking that it is like the other coronaviruses, but then they found out that actually it behaved like an airborne infection. So now in the university, we're following the American standards. We are recommending an airborne precautions.
I have a small comment. أول شيء شكرا جزيلا دكتور طارق ودكتور عصام على the excellent presentation. And I just want to assure everybody, you know, I've heard from some of the staff and students that do we need to come to certain clinical sessions or in contact with the Department of Medicine, let's say seeing some patients and so on, or some of them even attending grand rounds, the morning meetings for all the departments. So I said, definitely yes, you can. I'd like you to comment on that, you know, and if there is anything risky to any one of the staff or students working in our hospital or faculty of medicine, we will definitely be the first one to make sure and to take all the precautions to protect all of you. This is number one. Number two, as long this was started in 2003 as a question, then 2012, and then now we are having in 2014. Why they did not work hard to get a vaccine from that time? You know, I think as long as it is viral, you know, most likely the vaccine is the clue to reduce the chance. This is so now they are working hard, and we've heard a lot of news that, you know, probably a vaccine is going to be coming, which is already announced in the newspaper from the Minister of Health, and some of the other, you know, media saying that, you know, staff that can make some vaccine from, you know, looking after the research of camels, etc. You know, I don't want to mention names. So what's your comment on that? So what's your comment on that?
Thank you. Excellent comments. أجاوب السؤال الأول if you want to comment on the vaccine. بالنسبة a lot of students و families of students and families of doctors even, and even maybe my family and Mahmoud's family are worried about us to come to hospitals and work in this really outbreak. Actually, there's nothing to worry about. من ناحية مستشفانا, alhamdulillah, everything is under control بفضل الله سبحانه وتعالى. We have excellent standard of care من ناحية facility design, professional practitioners, nurses, infection control practices, excellent infection control team, and here everybody is following the proper infection control measures. So there's nothing really to worry about. And the situation may not be valid or the same for other hospitals. And I discussed this with say the dean yesterday. He said, and I agree with that he wouldn't really send students or sessions maybe in other hospitals, ما حسميها, in other hospitals في المكان. So just one comment that I want to say about the vaccine. Even if they ask a company to produce a vaccine now, it won't be before 2 to 3 years. You know, to develop a vaccine, if they succeeded to develop a vaccine مثلا within 6 months مثلا على أحسن تقدير, it will need maybe 2 years to become validated and experimented, etc. Well, and I don't think it will be easy to develop a vaccine against coronaviruses. They are really more difficult even than influenza viruses. For influenza, we have to renew the vaccine every year. For corona, I'm not sure whether we will succeed or not. For SARS, they tried a lot for SARS, and they failed. So don't be very optimistic that the companies will be able to get a vaccine. أنور.
تفضل يا دكتورة.
دكتور أنور
We have a couple of questions من الناس online. أول سؤال, what is the duration of home isolation for those who have tested positive but are asymptomatic?
واحد بالله. Okay. How long we keep patients under isolation? There is no guideline on this. Our own guidelines that we developed here as a policy is that we should not discontinue isolation until the secretions, the nasopharyngeal swab, is confirmed to be negative on 3 consecutive days. Jazakallah khair, Isam is helping us a lot. We send them the specimens on daily basis, and once the patient becomes negative, we repeat it again. If negative, we repeat it a 3rd time. If negative, then we discontinue isolation. We had a patient who had 2 negative, and then the 3rd one was positive. So it has to be 3 negative ones before you say that the patient can safely be released to the community or to the ward.
The second question is, does the virus cause mortality in camels?
Mortality in camels?
Yeah.
No, and interestingly, in camels, at least the camels we saw, and maybe the camels described outside, they don't get actually severe illness. They just get cold, like the cold we get from other coronaviruses. It is just mild rhinorrhea and fever, and then it is self-limited. The camels اللي شافوها البروف الطيب مع الفيترينيين اللي أرسلوا البروف الطيب مع الزملاء were actually just having lethargy, and they are not as active as usual, and they had fever and rhinorrhea, and then all of them recovered fully. So it just caused like cold symptoms.
Thank you, Dr. Tariq and Dr. Assam, for this nice presentation. I just have a couple of comments on the vaccines and on the camels. First, the camels, they appear to be reinfected even with the presence of neutralizing antibodies, which might mean that they are the natural reservoir for the virus, similar to wild birds in influenza. For the vaccines, Novavax, or they're developing DNA vaccine, mostly based on SARS experience, never tested in clinic. It's preclinical studies only, immunogenicity studies, no challenge studies since there is no animal model for MERS coronavirus except for the monkeys. I don't think this vaccine will go to use soon at all, especially with the fact that spike-based vaccines with SARS induced enhanced pathogenesis. So antibody-dependent pathogenesis was observed. That's it. Thanks.
Yeah, I agree. Dr. Anwar is an immunologist who had good work on influenza virus and immunogenicity of other viruses. And I totally agree with you that a vaccine is not really expected to be developed at all. And even if it is developed, it would take a very long time to become really introduced in the market. Sorry? Last question, yeah. Thank you. Excellent. Excellent. Excellent comment. Actually, the infection control is working on writing the instruction. You know that this is not safe because papers cannot be cleaned. So we have to develop these Arabic instructions, and we should laminate them or put them in glossy, transparent plastic, and then post it everywhere. We'll do that. We'll do if it is not done yet.